Since the 1960s, locally managed, publicly owned community healthcare has been a reality in Skagit County. From that initiative, the nonprofit Medical Information Network North Sound, MINS, was formed and a health information exchange was born. In 2008, with modern facilities in place, the Skagit-based public hospital districts came together with independent providers to take the next step, linking care electronically. As the model for care has shifted to providers working at the top of their licensure, there is pressure to move patients to care settings of less acuity. Scott Hale, the administrator of the skilled nursing facility Mira Vista, noted, "We've become the med-surg, the orthopedic ward of 15 to 20 years ago."
Nowadays, with the pressure from the third-party payers, the managed care organizations, Medicare, all the entities that have to pay, they're all limiting the reimbursement, and so they're putting pressure on the acute hospitals to discharge their patients much more quickly. Running that type of facility that has so many short-stay patients that come in so quickly can be a real challenge for a facility. We very often will admit five to six patients on a Thursday, Friday, 2 or 3 more on a Saturday and a Sunday. So our ability to coordinate the care of these residents when they come in is very critical. We don't have a lot of time. We have to be real cognizant of the fact that we have nurses that have limited availability, and the patients all need their care provided immediately.
Over the course of the last 2 years, I've been working with Skagit Regional Hospital on care transitions, improving the quality of care provided to our patients in our community that need our skilled services. It offers patient-centered care for patients, information about their individuality and their special care needs, can be readily available to any service out there providing care to that patient. For example, the ER could have that information, the physician in his office can have that information, a Compass mental health team could have that, the hospitalist could have that information, and also the skilled nursing facility can have that information when they're following that patient throughout their continuum of stay. Patient safety, so medication error is probably the biggest risk for our population. So patient safety, you can easily go in there and see the last notes by any provider or consultant. The labs that go along with medication review can be reviewed in there. Their diagnostic tests can be in there. Another piece of the exchange that I think is really important is that collaboration. In today's age with healthcare changes, that need to collaborate with all the providers in our community is vital for our patient safety, but it's most importantly vital for the quality of care that our patients feel when they leave any setting that they may be in.
So what we're starting to see is I'd say a higher level of coordination of care between our facility and the acute hospitals we partner with. We've, for example, been working on special task force with the hospital to develop electronic online transfer documents and prearranged orders, so that the old days of the orders coming over as paper, where the nurses would have to transcribe them, interpret them, and then load them into our computer system, is now being changed over to a new system where it's all online. The orders electronically come over. We certainly verify them, but they automatically flow into our electronic database, and we can act on them much more quickly with significantly less nursing time, which means the nurses can spend their time taking care of the patients.
Here at Mira Vista, what we're piloting is a physician clinic, where a physician can have all their forms for review, so they don't have a stack of forms on their desk. They can actually just review all the electronic forms that are required. In today's environment, there's a lot more documentation that's needed to justify for care. If we can make the process easier for physicians, it allows them more time for assessment, more time for patient evaluation, and more time for teaching their patients and building that rapport with their patients.
We used to see patients that would come in and maybe see their doctor once a month. Now we see patients that come in and they see their doctor every day or every other day. We're really picking up the tail end of the acute care stay.
Okay. I was so excited when MINS came in here, because it was like the first thing in such a long time that gave people that do the jobs that we do every day hope. that we can get out from underneath all the paperwork